So this is the outline of my talk. Okay, I have to sit for this. We're looking at the burden and epidemiology, some definitions, couple of case histories, and then look at a few things that happen when we are dealing with patients with AUFI. So if you look at a case definition, it's an old ICMR definition, but I think it kind of fits. You're looking previously healthy, non-immunosuppressed. Community that could be urban or rural dwelling adults, reporting no previous medical illness or recent hospitalization in the preceding 30 days. Of course, you could take off all of this and just say people coming in with no previous medical illness or recent hospitalization. Or you could just take the second definition, which says presenting with acute fever for more than 2 days, lasting up to 14 days, and receive no specific treatment. It could be seen at any level and with a history of no localizing symptoms, which is why we're calling it undifferentiated, and usually has normal vital signs except fever and lacking organ or system specific physical signs. So all of this can have its own problems. It can be in any population. So we can't say only till 64. Definitely more than 18 because we are. But can we say previously healthy or can we say normal vital signs? Sometimes it doesn't exactly fit that way. But this would be a case definitely maybe of someone who comes to OPD and you're not going to kind of admit then an AUFI classification here. But otherwise, you're looking at the temperature, you're looking at the duration of symptoms, and you're looking at no localizing. Those are the 3 points that you can take out of this for an AUFI. So a complete and thorough physical examination is necessary, record of vital signs. Look for hidden foci, which we've kind of reiterated many times, throat, sinuses, any kind of organ area tenderness, murmurs. Make sure the chest is clear, lymph nodes and splenomegaly. And a fundus examination, especially if they're saying headache or bleeding tendency, and look at the skin very carefully. But having said that, acute undifferentiated febrile illnesses are not necessarily all infections. But in our tropical row resource settings, you're saying infection, you're worried that the patient will become more sick. I'll later look at some non-infectious causes also, just so that we complete the lecture. So the Slido is not working on this, so don't try. Okay, I just got enthusiastic, but it's not working on this particular computer that they gave me. So what is the commonest AUFI in India, can I ask? You can shoot whatever name you do. The Slido is not working, so we are just going to take it. Yeah, sorry, dengue. Okay, so map. This was actually a systematic review looking at the diversity of infectious etiologies of AUFIs in South and Southeast. The circle sizes are based on the number of studies. So obviously the largest number of studies are coming from India. And if you look at the light color and dark color, light color is actually unknown etiology and the dark color is actually what is diagnosed. And I'll come to what is the diagnosed side. So unfortunately, if you look, half of our areas do not have tests. So it's more based on an algorithm of treatment depending on where you come from. So, and some studies are just done saying we treated like this, the patient got better. So the studies are there, but the tragedy is that we still have a lot, almost more than 50% where we don't know the diagnosis. I'm coming to 2 studies done in CMC. I'm sorry, between the reflection here and there, it's shining. So I'll just show my screen. This one was done by Dr. Abhilash in 2012 to 13. Over 1 year, all patients who came to ED with AUFI, they looked at 1,258 patients and there was 42 or 3% deaths. You would think nobody should die of an AUFI. The other one was done by one of my contemporaries, Anugrah, during 2008 and 2009. He looked at in-hospital patients admitted with AUFI, 398 patients, again over a year, and there was 11% death. So it makes sense. If you see ED, some of them may go home, some of them will get admitted. But there is almost a problem of death. Now, in this, if you look at the first data, which is Abhilash's, scrub typhus was the most common, followed very closely by dengue and malaria, enteric fever, leptospirosis. Okay. Now this side, when you look, and you can see there is a smaller box here with spotted fever, UTIs, TB. These are the unusual ones. They won't come in as AUFIs usually, but maybe sometimes people can present like that. In Anugrah's study, again scrub typhus. So that just tells us that for our epidemiology, at least for the people who come, see, people are going to be local area when they come with an AUFI. It's very rarely that you get a person from very far away. Scrub typhus, malaria, enteric fever, dengue, leptospirosis, spotted fever, and hantavirus. I'll come to hantavirus also. There was a Kuti outbreak at times, sometime when we were junior consultants. Alternative, again, you can see focal abscesses, UTIs, viral meningoencephalitis, TB. There is also unclear diagnosis. So you're kind of getting an idea. It's the same things, but scrub and dengue would be there, and we shouldn't forget malaria as much as we don't see it so often. This was done by Dr. Dilip Matai with all the mission hospitals. They looked at fever in India. Multi-center was all the mission hospitals. Now you can see what switched. Malaria went up. Because if you look, there are a lot of areas in our country where malaria is still, unfortunately, not controlled. And then dengue, the bacteremia was more of typhoid, if you look at 35%. But in a smaller setting, in a secondary hospital setting, people may be very sick but come a little later saying short duration symptoms. That's why they're coming into the AFI bracket. Here, our bacteremias are very different. We get referred patients who may have been treated elsewhere. Okay. So that's why that bacteremia is creeping in there, though we wouldn't call that an AUFI, but typhoid can be a bacteremia, is a bacteria rather. Scrub typhus, lepto, and chikungunya. So that's something that adds on another flavor to I think. And what you see that last line, fulfilling more than one case definition was common, which means the AUFIs overlap so badly that sometimes you have to break your head to see what am I going to do, and a lot of empirical treatment then comes in. So this was done with our mission hospitals. So you're getting a flavor. These are studies done by people we know, and either locally versus across the country. So there is this thing, I took it from the BMJ 2018. It's a nice article. You can look it up. I think Ravikar also was a part of this study. And it looks at this mnemonic called MAESR, where you have all malaria, enteric fever, spirochete fevers, and rickettsial infections as the 5 main groups that cause AUFI. I've just highlighted the ones in yellow where what we are going to likely see, which could include Plasmodium falciparum and vivax, dengue and chikungunya, salmonella, paratyphi and typhi, leptospirosis, scrub, and spotted fevers. Okay, among the list that we would see. Now, others, remember, hepatitis A and E can be a fever till the patient actually develops jaundice and starts vomiting a couple of days. Brucellosis really depends on when you catch these fevers. The patient may come early in their diagnosis, and early viral respiratory infections, as we all know, be it influenza, COVID, all of them can just come with fever to start with. And then the patient develops respiratory symptoms. So this is there at the back of our heads, but they don't come into the classical group of AUFIs. So you'll realize anywhere you look up most studies done in the world and India, they'll say malarial and non-malarial. If you look at divisions of AUFI, it'll always say that, because it's a historical context of malaria being the global AUFI, and with a lot of government level and WHO level control, testing, rapid testing and control. And somewhere in 2013, this Lancet Global Health, they had this article when fever is not malaria, where they discovered the other organisms are now coming up and malaria may not be the only AUFI. So at that time, they had a consultation, and then it got divided into AUFI. You can see this acute localized and acute undifferentiated, and under that, there is malaria and non-malarial. So we don't forget malaria because it's still there. It's not as well controlled as we would like it to be, but there are non-malarial. So that's the background, historical background of all divisions of AUFIs, by malarial and non-malarial. Though in our heads, it may be scrub and non-scrub or dengue and non-dengue, but this is how it is. Just to remember, if you look at this key over here, this is for malaria, just to jog our memories. So all blue, light blue is less than 1,000. If you're looking at the, burden of malaria. We are here, Tamil Nadu, Andhra Pradesh, Karnataka, which is like 10,000 to 50 per population. It's the intensity. Sorry, I've not got the range properly. Odisha is still suffering from it, and so is a lot of middle of India. Can you see this area? And having said that, it's falciparum here in Orissa. Vivax more if you look at Chennai, actually more than actually Vellore. And here, area again, it's falciparum or mixed. They can have both. And we'll come to why we need to know that. So when you approach to an AUFI, local disease prevalence, we've seen it, scrub dengue kind of thing. Go up north, go middle, you'll start with malaria first. malaria, arboviral infections, scrub typhus, and leptospirosis. Potential exposures to animals or mosquitoes or wherever you live. Host factors, of course, age, comorbidities, immunosuppression, pregnancy, and elderly. Assess for severity and triage and rule out localized infection, which I mentioned earlier. The same study that Abhilash did, if you look at the seasonality, this is the blue line, is scrub typhus. You can see August, September, October, November, December, Jan, Feb, March. Little cooler, it's also a monsoon season. Dengue, a huge spike during the monsoon. Okay. Malaria is kind of running there because we either get it from AP or we get it from Chennai side. Okay. And salmonella is the last line, which it's there. You eat outside, you eat enough, you will get it sometime. So these are potential clues. I won't stop much on these. These, you know, we are looking at different areas to see if there is a localization to your AUFI. Okay, this is just different estimates, but I'm stop here. But if you look at organ involvement, again, I'm sorry, I thought it'll be clearer. The blue lines is hematological thing, which is common across scrub, dengue, malaria, enteric fever, and leptospirosis. The red is RS, which comes up a bit in lepto and scrub, but not so much in the others. Hepatic involvement is that yellow line, and renal is yellow. So hepatic, hematological, and renal will be the common combinations. I'm just putting my syndromic approach like this: fever with rash, fever with leukopenia or thrombocytopenia, fever with the hepatorenal syndrome, fever with the pulmonary renal syndrome, and fever with GI symptoms. You already know in your mind's eye what bugs are going to fit into that. I'll mention some caveats which I have discovered with clinical practice. So this is a 22-year-old woman, fever for 4 days, vomiting for 2 days. She was apparently well. She developed high-grade intermittent fever with chills, with fever and body ache. She had non-bilious, non-bloodstained vomiting. She had multiple red spots on her limbs, no gum bleeding, blood-tinged urine, or other blood. She was tachycardic, febrile, dehydrated. She had pallor, fecal lesions on both low limbs, and a blanching erythematous rash on chest and abdomen. What are you all going to say? Okay. So I'm not expecting anything else, but that is one. I'll come to some other differences later. HB was 9.5. You can see that classically, I have not put a total count here, sorry. Her total count was some 3, 4 or some, it was low. With no particular shift. Platelets were 1,21,000. Enzymes were a little up. So if you had to define it further, what would you call it? Liver involvement, she has a rash. She's got vomiting. So dengue with warning signs. Okay, so that's where you're looking at some of it. So some of the warning signs are subtle. Some they're young, so they don't look like they're tolerating anything. But it's clear by all of our guidelines what you call as warning lines. So this is similarly patient 2, 34-year-old man, fever for 3 days, generalized body ache with retroorbital pain, a headache for 3 days, otherwise well, no rash, systemic symptoms are normal. He had 3,600 counts, maybe a mild elevation of SGOT and a platelet count of 98,000. What do you want to say? Dengue, and may not have any warning signs. So the slide of that. This is something I'd written up for a book. So I'm just looking at fever with rash. These are all rash, different types of rash. The non-infectious causes are in italics. Okay. And all that has one next to it, it needs immediate treatment. So if you look at a central maculopapular rash, it's viral exanthems for what we are doing today, and acute HIV. If you do a peripheral maculopapular rash, you're looking at Rocky Mountain spotted fever, which we see. And, it's classically got this peripheral rash. I mean, you have to see one to remember one. I'll put it that way. I've put a 1 next to it because it's potentially lethal. So this is somewhere where you're jumping in on empirical treatment if needed. Okay. Dengue, of course, and erythema multiforme, but that may not be an infectious cause directly. If it's confluent and desquamative, toxic shock syndrome, that doesn't come. We are just doing the rash part. Purpuric, viral hemorrhagic fevers, or a Rocky Mountain fever again. Meningococcus. Remember, this is not AUFI only. I'm just looking at rash and fever. Nodular erythema nodosum, but that could be infectious or non-infectious. And eschar and vesicles, of course, you're looking at rickettsial fevers and varicella. So then I go to my third patient, fever with a hepatorenal syndrome. He's a 58-year-old electrician. These are all patients. This is off our workstation. These are all actual people who came with fever for 1 week, generalized tiredness for 3 days, reduced urine output for 1. Fever, had chills. There was myalgia, generalized fatigue. He also said decreased urine output. There was no rash. He was icteric with bilateral pedal edema. You can see the LFT derangement. There's an increase in his bilirubins, HCOT, alphos mildly. Creat was 3.92. His total count was high with a shift. HP was 10 and platelets were 1,74,000. Yeah. So ELISA for lepto came positive. Do you want to know any other history at this time? Yeah, where in heavens? I remember this electrician. So it turned out that there were floods in Chennai. And he kept on going into the basement of the building because things kept on getting, what is that called? Short circuit. Because I asked him, where in heavens did this electrician go? So he said there was a lot of water and he was going in with his chappals. It had flooded into the basement and he kept going. So curiosity, and I got the answer. So the other history that we want, as we classically said, was how does one get exposed to what? What? Yeah, what? Urine. Okay. Which is why you have the classical history of soldiers in trenches and things. So you need someone who's working with water where there is trenches and the feet are exposed. I mean, the skin is exposed to it. So that was his history. So you can realize that most diseases have crossed the rural boundary and become urban because of the way we have built and done. Unfortunate. And they may have these subconjunctive hemorrhages and they look frankly ectric. Now, I'm repeating it for a certain reason. Now, what if this was a 58-year-old electrician? Same guy, okay? Now, I just want you all to note one thing which I didn't see. Any things about the leukocytosis? Remember, there's a huge shift to the left in leukocytosis. So that for me, I would look and say, hey, what is that? So in leptospirosis, you could get leukocytes. Because normally, it's a normal count. It's not like a low count like you would look in virals, but it can be normal, but you can have leukocytes. See, someone like this, I'm jumping and dying to put antibiotics on also maybe, but the syndrome is that we are talking about AUFIs, but that count can put you into kind of quandary of, is it a system, multi-organ dysfunction, what is happening, and whether I would cover with an antibiotic bacterial cover. Just to keep at the back of your mind, because when patients like this come to casualty, there's not much room for thought. Same man, okay? Now what I have changed is that the count is 3,400, the platelets are 90,000. He's come from Chennai. Yeah, so it just kind of switched in their head. But the thing here I want to know is any other history. What is it? Where did this person come from? Okay. So one is the exposure to it, like we discussed with the others, where they traveled from. Did you travel from Andhra Pradesh? Did you travel? Otherwise, we don't see so much malaria for the plain reason that our catchment area is like that. But as a PG, I saw lots of malaria. So I think that indirectly reflects on the control programs. It doesn't reflect on the fact that we are not seeing it so much, as fortunately it's been controlled. So malarial and non-malarial, that's where the thing is. He had a smear for falciparum positive, malaria positive. Okay, this patient I had to kind of modify a bit. He originally had leptospirosis. Okay. So now I'll come to pulmonary renal syndrome. So let me put the same patient. Okay. Now this patient starts complaining of dyspnea. He's had fever for a week, right? And then he starts complaining of dyspnea. And when you check his RS, says bilateral crepitations. Now tell me. Which was this? You'll think of scrubs. So I agree. The thing is, we've not had many icteric scrubs. If you look at it, they come with hepatitis, but it's more of that hepatocellular injury. But the icterus part is where you kind of tilt towards leptospirosis, right? When they come and say when they have icterus. So could it be scrub? Anything else? I'm not denying this. I'm not going to give you an investigation. I'm just expanding our differentials. So this is where that one mention that I made. Sorry, somebody said something. Yeah, okay, because we're going into the second week. You're going into the organs that come in. Funnily, even salmonella, we see more of transaminitis and not so much an icterus. Okay. But now I'm going to an unusual diagnosis. I'm just saying it because we have seen it. And so, what does patient 4 have? So, I'm coming to hantavirus. Now, why am I bringing up hantavirus? We did have a Kutti outbreak. In fact, there's a variant of hantavirus called a Totapalium virus, okay, which is supposed to be very specific. And during maybe a couple of years, we actually did studies to look at hantavirus in our area. So hantavirus, it depends on rodent population, but this is an inhaled thing. You have to inhale the rodent secretion or whatever. It's not a walk in the urine type thing. Huh? And it may have three kinds of presentations. I'm sorry if you can't see it. Shock with multi-organ failure, acute renal disease, or acute undifferentiated febrile illness without renal failure. That's our spectrum. But why did I bring in the pulmonary? Because in the Asia, Southeast Asia, we are a hepatorenal syndrome with hantavirus. In the US, it's a non-cardiogenic pulmonary edema. So there's the pulmonary renal syndrome of it. So it's actually a pulmonary hepatorenal, just the hepatorenal. So when you have these guys who have negative for everything, at the back of your head, you can wonder about Hunter. Because we do have patients who come with hepatorenal and the leptospira is not positive, and you're wondering what else does the patient have. So the other thing is it's a ELISA system for diagnosis, but they say it's got a very transient kind of viremia and effect. So sometimes you just don't pick it up. And treatment is supportive. Okay, it's more of supporting the respiration. But fortunately, we are a hepatorenal syndrome. In the US spectrum, it is more of a pulmonary. Pulmonary being a non-cardiogenic pulmonary. So I've taken this. The study was done from Velo. It's all online. You can have it's published in 2009. Now, fever with GI symptoms is a 30-year-old lady who comes to OPD with fever for 20 days, flu stools for one. This lady actually came to OPD only. She didn't come to casualty. She developed fever. It was high grade for 20 days, associated with nausea and loose stools, 2 to 3 episodes per day, small volume watery. She had some headache and myalgia. She was dehydrated. BP was 90 by 60. Her pulse rate was 80. She was febrile at 102. And she had mild diffuse tenderness on her abdomen. What are the things that are sticking out? Other than the syndrome that I've told you, it's a fever with GI symptom. So that 80 per minute, and also the fact she's spiking at 102. She came to OPD. This is a lovely part about typhoid. Not lovely, I can't call any illness lovely. But the fact that they feel well, they don't feel actually sick, and they actually come to say, but sometimes by the second week or third week, obviously you can get complications of other systems beyond the GI tract. So here I've got that relative bradycardia, famous thing that I keep talking out quite a lot, where you don't see a variation of the pulse rate with a spike in temperature. Okay. This is the other classical thing. Now, why have I put this? Because remember, once you get your diagnosis, your enteric person will be bugging you, but the fever will not be coming down. So if you have a culture positive, remember the fever is going to come down by lysis. It is not going to come down immediately. As long as you have a positive test. You can stick your neck out and say, hey, you'll get better. You just have to wait. And that's the problem with typhoid. Well looking will have a symptom unless they have other organ complications. And will take some time for the fever to come down by lysis. So to remember that it will look like that, and there's almost like a continuous fever pattern, some variation not touching baseline. Because we're talking about that, can I just bring back one more fever chart? Please tell me. It's already labeled here. You can see the remittent fever as compared to continuous, and you can also see intermittent fever. The patterns are sometimes confusing. As much as it's a textbook description to say if you have this fever equals that, not all the patients can tell you that. And if they take a paracetamol, they are going to have intermittent fever. We can't actually get a fever pattern. Now, can you see that drop by crisis? This classically is seen in bacterial infections, where if you give the right antibiotic, it crashes as compared to this. So some years ago, when scrub typhus first came into endemicity here, you'd had drop of fever by crisis. You gave a doxy, chuck, the fever would come down. So even before the result came of the report of scrub, your doxy will tell you whether the patient had scrub. If you didn't have a eschar, of course, eschar is also pathognomic. So there is this, but I think we think over time maybe some amount of resistance and variation, so we don't get that kind of chuck coming down. But we've actually seen that. So fever with GI symptoms, as I said, the count could be normal, or you could even have a lowish count. That's what will differentiate from a viral. A viral will not be sitting for 20 days. So the count is low, patient hectic fever, looking well. I would always put my money on Enteric, and I'll do, of course, investigation. Some transaminitis, which is in the hundreds, and CRP was up, and this particular patient grew Salmonella typhi. Some cases, I told you the relative bradycardia. And then when they have other organ system involvement, especially CNS, they have this unusual bed picking movement, which we call jactitation, or they pick beds, classically described with enteric fever. I like to stop here and just bring up few more caveats with the others. So remember, in dengue, you can get an extreme drop in count, which can even go into 1,200, those kind of counts. But you kind of know your diagnosis, so you're okay. You can get a severe relative bradycardia. I've seen that when the fever goes down, heart rates drop to less than 60, and it's scary for everyone. But it's not anything. It's just severe relative bradycardia. That happens with leptospirosis. The myalgia, you should also check a CPK. Those are the tests that help you with leptospirosis, and it can be a biphasic fever. Okay, so the patient may be better and then get fever again, but it's a hepatorenal syndrome. So those are few things that you'll just, as you see more patients with. So now I'm bringing the same patient. We talked about a fever with GI symptoms. This particular patient, this is true. This is the patient's result. Also had a scrub typhus test positive. Now what leads the way? In the two tests, what leads the way? Sorry, couldn't hear you. The blood culture. The blood culture by far leads the way. There's no question about what is, and of course you have a syndrome, but your blood culture is going to lead the way. But this patient also had a scrub typhus positive. So now we come to this confusion when we get two tests positive. We've had that. It's not been unusual where you can get two tests positive and you're okay now. If they're both viral, great. You don't do anything anyway. But we'll just look at what to do with this. So I'm just going to, before I go to this thing about two tests positive, the same study which I quoted from earlier has a visual summary. Unfortunately, I realize in this computer it's not going to be clear. Okay, don't worry, busy slide. Can we look at it in horizontal columns, please? And look at blue. Blue is non-severe disease and the symptoms as the circle fills is from rare to common. Triangles are severe disease, and again the symptoms from rare to common. So look at malaria. If you have a non-severe disease, correct? What is going to be your commoner symptoms? Maybe an enlarged liver, maybe like recurrent episodes of malaria, and you may have a thrombocytopenia. Okay. Now, if you have a severe disease, the commonest symptom is jaundice, enlarged spleen, acute, maybe shock, thrombocytopenia. Right? We're going downwards. Let's go to enteric fever. Maybe an enlarged spleen. What type of splenomegaly are you thinking of in enteric? I'm just talking about small, large, or very large, moderate. It's a small. It's a cootie thing, and I've often told a spleen, this quoted by one of my professors, is a shy organ. You have to wait for her to touch your hand, which means it's a soft spleen. You need to make the patient a maneuver and then make the patient breathe, and let's leave your hand there for this. That's when you get a small spleen. Now, if you look at the symptoms, again here, for severe disease, jaundice, enlarged spleen, maybe encephalopathy. Remember, we're going into organ involvement, shock, bleeding. But very honestly, that what I described earlier is what you see. Coming to OPD, high fever, relative bradycardia, count which is normal, and growing blood culture. Growing enteric in the blood culture. Scrub typhus, obviously non-severe disease and severe disease has the S count. But lymphadenopathy, so this was a little unusual. See, we don't see this. So I don't know which area that would come from. Scrub typhus and lymphadenopathy. And of course, thrombocytopenia could be there. Here there's enlarged. It goes through the whole spectrum. We've all seen severe scrubs, so it's okay. Leptospira, the conjunctival suffusion, that's classically described. And muscle tenderness, which I mentioned earlier. Acute renal failure and shock in the severe forms with thrombocytopenia. Dengue, as we said, rash can be both severe and non-severe. So this study was the one which was done by Dr. Anugrah, the second study that I showed you. So they compared certain symptoms for each AUFI versus the other AUFIs. I just like you to look at the ones where the p-value is less than 0.001. So if you had AO5 with dyspnea, headache, respiratory cramps, neck stiffness, as compared to other AO5, more likely to be scrub. That's, they had to just compare it. When you look at enteric fever, if a younger age, because eating outside, fever, duration of 12 days, yeah. Loose stools would all mean as compared to other AO5s. So we've already described the syndromes. I'm just putting it in our own patient group. When you look at it, it holds good. When you look at dengue, look at the significant ones, retroorbital pain, overt bleeding manifestations. Okay, that's, we agree. So anybody saying retroorbital pain with fever, you're looking more at dengue. When you look at malaria, fever duration about a week, hepatomegaly, splenomegaly, and a low HP. The drop in HP thing because of the hemolysis is something that you'll be worried. So the concept of mixed infection. So if you look up these tests being positive, they can be called mixed, they can be called co-infections. When you're saying mixed, it's more than one organism. When you're saying co-infection, maybe like two of the same, like two virals. So that's how you're going to define it. For example, that person had enteric fever and scrub typhus. What are you going to call it? I mean, the reports came like that. I'm not saying he had both. It's more of a mixed. But a co-infection will be two viral tests coming positive at the same time. It is an entity, but having said that, it's usually picked up on lab tests. Your clinical findings, you're sure it's only one disease. You're not usually confused unless it's a hepatorenal syndrome. But you're worried because it can worsen a disease or make it better. Various people have studied mixed infections and not come to a conclusion. They have just said, some say it makes it worse, some say it makes it better. There's no particular tract. And this study, if you can see, there's M plus S, malaria plus scrub, D plus S, dengue plus S. These were all the numbers, 14%, 9% were all mixed infections. But you usually base it on clinical exam and treat what you think is a thing, unless you have a blood culture positive like that lady. She had both enteric and scrub. I won't waste your time much on this. I'm just saying that the IgM ELISAs are what we usually use. They are based on cutoffs made in low endemicity areas, which makes it a problem in high endemicity areas. And when you do single point serological tests, you'll end up with cross reactivity. So ideally, it's a molecular test, which is a PCRs, which are very definitive. Now, we don't wait for doing PCRs for each of these. We're going to treat. And so at the end, plausibility of cross reactivity or genuine dual positivity cannot be ruled out without molecular tests. So you treat, if you think the patient is very sick, you cover for both. Otherwise, you're going to give only one. Yeah, this was in Abhilash's study also. They saw 7.6% had dual diagnosis. Dual means serology being positive. You just have to keep that at the back of your mind and go ahead and treat. But it's a true thing. It does happen. Sorry again for this, I didn't realize, but it's in the same BND summary. It's an infographic. If you can take it out, it's good. Why I brought this is again, please go horizontal. The rapid test is the RDT, the rapid test, which can be done like a dipstick, sensitivity and specificity very high, which is what made it very useful to get malaria out of the way in the country. You know, just do it. And the next is microscopy, which is what we do, which takes about 20 to 30 minutes. If you go to enteric fever, there is this Typhi dot test. We don't do it anymore. We rather go down and do the culture, right? We are doing the culture, which will take 3 days or 6 days, or we can do the viral test, but it's a paired. Ideally, you should do a pair. We are looking at cost also. You can see it's quite inexpensive. So is the microscope. Look at scrub typhus. The ELISA, what we do, it's a medium cost test. It can be fairly rapid if you want to. The immunofluorescence assay is the gold standard, but it's a very expensive test. You can do the wheel Felix, but it can pick up any kind of rickettsial. You may not be sure that it's scrub. Leptospirosis, we classically can do the ELISA, yes, or we can do the MAT test. It's expensive, but it's available here, but that's can be done only later in the illness. This is the quick test. And for dengue, of course, you can do your NS1 and IgM early, and you can do your PCR later and the IgG. So antigen-based test within 96 hours, antibody-based test is 5 to 7 days. So the dengue rapid and the RDT malaria, all of them are the rapid ones. Then the IgM and leptospirosis, which are all antibody tests. And you know you need a blood culture or a bone marrow culture for enteric fever. You could always do a Vidal, but that's in the second week based on the BASU formula, where you do it in the second week. Point of care test needed? Yes. This is something that has been being developed. It's called a global fever panel. You do it on whole blood. Remember, at a peripheral center, you may not be able to do, like spin it and get just the serum on whole blood. And they're hoping that within an hour, this will tell you what the person has. They're developing systems like this so that the morbidity and mortality from AUFI comes down. We have a huge lab backup. So for us, it's not a problem. We have a huge everything backup. So it's not a problem. So to treat or not to treat, difficult because different parts of the country will show the illness differently. Each pathogen behaves differently and tests are not easy. But RDT and for dengue and malaria are available across the country. So based on severity and comorbidities, either you're not treating or giving them doxy or azithro. Because this is somebody that can go home and come back. Now between 500 and 1 gram, unless you have a high pretest possibility of enteric, I would stick at 500 anyway. If the person can't take doxy, otherwise doxy is going to prickle drug of choice. That I think everybody knows. What are the side effects of doxycycline? Gastritis. So gastritis and pill esophagitis. In my bond once, there was a guy whose pill got stuck to the esophagus. It just got stuck. It sticks like that. So ask him to wash it down with a lot of fluids because these are sick people and they may not drink so much water. And this I've taken it from our own manual. This is from our HICC manual, where we're looking at treatment depending on the resistance of enteric fever with azithro is usually 1 gram. Amoxicillin double strength. Alternative is ceftriaxone 2 gram IVOD for 14 days. Scrub, of course, doxy IV oral, or you could give azithro for 5 days. Vivax, chloroquine phosphate. You know the dosage of taking 4 tablets on day 1, and then after 6 hours you take another, and then you follow day 2 is 4 tablets, and then 2 tablets with primaquine for 2 weeks. Plasmodium falciparum, of course, we are looking at all OPD choices here. You can take 4 tablets twice daily for 3 days. Of course, primaquine, you need to look at T6PD deficiency. Severe malaria, you're giving injectable artesunate. Leptospiro, again, is doxy or azithro, and you can add on ceftriaxone if the patient is sicker. Now, when you look at all of this, few things to know, as we have said, azithro, when you give an IV infusion, dilute it with a larger volume of fluid. The patient inevitably at 1 gram will tell you there's pain. So dilute it with a large and keep it a slightly slower drip. So remember, there is a doxy azithro. There's a recent study. Now, why did we ever start using azithro is historically in the way that we had only oral doxy. So in severe scrub, when the patient's absorption characteristics are different, we started overlapping. We started doing doxy and IV azithro because we didn't have IV doxy. Now IV doxy came along, and we, of course, have recent studies to say combined may be better. But that's how we started off with doxy azithro combinations as a personal experience. Malaria, of course. And here, when we were postgraduates, we were giving quinine because quinine resistance was not there. But quinine has its own side effects of synchronism and cardiac side effects. So artemether is fairly safe. Can I just ask a question because of my obviously affiliation to obstetric medicine? Is that what would you do for instead of primaquine for malaria Vivax when you're doing it for the extended phase? Primaquine is, you're worried. You don't know whether the baby will have or the mother will have. So you treat it like a malaria prophylaxis. You give them chloroquine every week instead of primaquine. That's just something that we change. Unless it's same thing if a person has G6PD deficiency. And leptospirosis, we have said doxyazithro. I know we do give carbapenems at times because the patient is looking sick. There's no contraindication per se, but it's obviously an expensive drug as compared to ceftriaxone. So if a patient came in well, doxyazithro, depending on whether they can take as a doxy or not. If they came in ill, doxy ceftriaxone is also enough. We get patients treated from outside, which is why our antibiotic kind of spectrum for bacterial cover becomes larger. You know all of this, red flags and who to admit. I just want to point out dengue has severe prostration. A person who comes to you and says, I just can't get up of any age, and then the next day has fever, I would put dengue on the cards immediately. That severe prostration is quite like severe pain, headache, back pain, retroorbital pain. Of course, high temperatures, low temperatures, tachycardia, tachypnea, pallor, jaundice, rash, low GCS, abdominal pain, which is severe with vomiting, and bleeding are all indications for admission. So, approach in short, don't forget this crowded slide. Day 1 or 2, defer everything. Just give them paracetamol and hydration in case they are dehydrated. Day 2 or 3, you may do a leukocyte count. We don't jump into malaria. We usually go on the endemicity, but if you're anywhere else in the country, you will do malaria and maybe dengue, depending on the season. More than 5, you add on the paired blood cultures. Do everything else. Chikungunya only if you have an arthritis kind of complex. More than 7, you're adding on the other tests. Somewhere here at more than 5, I might pop in and say, hey, does this patient need doxy? If it's an OPD, if they come to casualty, it really depends on the symptom complex that they have. So thank you. And that is the end. But there are very nice articles that you all can look up. I've tried to cover whatever I thought was needed in terms of the unusualness of AUFIs. Any doubts, I'm free to take questions. No. So when you look at doxy, it's always you have to question what are you covering. If you're covering an AUFI, definitely there's nothing going to happen by giving doxy for longer, even for bacterial cover for that matter, unless you have a collection that you haven't taken off, or fungal sepsis, those kind of things. There are certain indications for prolonged antibiotics, but not. If you can say which patient it was, I could even throw some light. I think. I don't think there's any evidence for the 14th day, but there is nowadays, even in clinical path, they look at the WBC parameters. You can look at indices on your WBC, which is quite specific. It's called the sizes of the indices. And they may give you indication on AUFIs. Now, this is very radical in thought. I rather go by the clinical thing, but not at 14 days. I'm not talking for antibiotic. I'm just saying, would we throw doxy to someone who's been in hospital for a long time and then gets a new fever? In my heart, I don't know, because how does a Orientus Susugumu, she landed up in the middle of ICU and come. But there are ways of looking at WBC indices which says, oh, maybe you get it. Now, is it that they always had it and it came out? But I find it difficult to understand. But having said that, not a prolonged course. Yeah.
Patients we evaluate for other causes. We find that one dengue IgM will be positive, one dengue IgG will be positive. Often people are still positive also. Sometimes we have some polyclonal.
Yeah.
But do we have to? Now they might have some other fever. They might not have a rash. So we monitor platelets for some time and maybe.
Yeah, that's about where I is. I always I worry that we send off a battery each time. This battery is expensive. Each of those tests are expensive. Depending on the seasonality, sometimes there are no seasons. It's just all over the place. I would not even send the test unless I felt the platelet went down. I would do it reverse rather than send it. But of course, as we said, you have to send it at the end of 5 to 7 days. I mean, not sending it in the first 3 days. But I would keep it and wait and watch. Very honestly, if you ask me what I would do, because I know the clinical situation in which the patient is sitting in. Monitor and see if it's relevant to what is happening. But the sending the battery gets us into trouble often because we don't realize then what to do with the result. Yeah.
These non-infectious causes, which should we say is the commonest one we should report for?
So I found DRESS syndromes to be fairly there. In fact, we had one lady who we took over back who had a VP shunt under neuro for TBM, then came back and then kept on having this fever. And CRP was high, Procal was high, unusually, because she had been in a hospital for long. Somebody had sent a Procal. I said it had to be better. And we were bugging the neurosurgeon saying the shunt is infected. Their poor souls were coming every day and saying there's not infected. In all of that, suddenly she was turning redder and redder. And she had been on phenytoin. She was on anti-seizure medication. So I found drug rashes to be this very quietly sneaking in thing. And eosinophil counts sometimes are not high. As much as I say address, you may not have it. So just check your drug list again. because that has surprised me because it is an inflammatory reaction. It is kind of a systemic inflammatory reaction, but not of a bacterial origin. So the drug fevers are my worry always. Even unexplained cytopenias. That's I would worry about prolonged antibacterials. Yeah.
Ma'am, is there a way to differentiate between drug fever and fever caused by?
Yeah, so we usually do the usual thing. We do the count. You're looking at a high count. I'm not saying eosinophilia. You're looking at if there's a shift to the left. But do remember, SIRS is always a low count or a high count. It can be both ways. I would send off the cultures and wait and watch. Now, for me, if you ask in my unit, I'll keep on harping about the CRP. So I like to have a serial CRP. Maybe I do one at the beginning of the fever and then do one later. And if it's actually low, it may not be an infectious cause. But somebody who's sick, no, who's already had one hit, come into ICU, go on and come out, I may give the empirical much faster. But I would look at counts, send off the cultures. Sometimes it's worth, after you're giving a course of antibiotics and the patient is still febrile, take off the antibiotics, wait for 48 hours, send the cultures. Because I think the faster you get to that decision, you don't get into an endless zone of empirical antibiotics where you don't know what made the difference, taking off or putting on. So that's where I am. I like CRP. So
For step time has doxy versus azithromycin, is there any consensus or,
study with Dr. Georgium Verghese from ID, we were all a part of it. We did it where doxy alone, azithro alone, and a combination, and the combination seemed to be useful. This is severe scrub. So it's published in NEJM. Yeah, sorry. So the interest trial. So please look it up. We all were a part of it, and of course, we did a lot of takatais in between because it's a severe scrub. You're itching to know whether your patient has the right drug on it, but of course, the study has to be done the right way. So Karthik was involved with Dr. Georgium Verghese, but we all were a part of the study as Department of Medicine because the patients come to us. But the history of the combined is this. And of course, there's this problem which I said, no, which we used to give doxy and it used to differ was chuck, which no longer happened. And there's a question of is the bug developing some form of resistance to doxy? Because we do throw doxy for all of our AUFIs and rightfully. So most WHO, ICMR, everybody will tell you to start doxy as an empirical, but in the right day. You don't have to start it in the first 5 days if you feel the patient is stable. Okay, thank you very much for your patient listening. Any doubts anytime, I will come here.